My name is Shil Punatar, and I'm a second year internal medicine resident at Franciscan Health in Olympia Fields. And I'm joined today by my co authors Ahmed Khalifa and Matt Gorecki, who are also second year internal medicine residents. Today, together, we'd like to present a case titled Why the Long Face? TIA Mimicking Induced by an Adverse Reaction to Valacyclovir. For us, the objectives today are going to be to shed some light on a lesser known side effect of valacyclovir, which is unilateral facial palsy as well as focal weakness, and also to take a look at adverse side effects of medications that are common mimickers for patient presentations. We also would like to expand and add a growing differential of patients who present with facial asymmetry, and to add to literature a lesser explored side effect of a well-known and often used medication. The patient that we'll be discussing is a 51-year-old female who has a history of hypertension and end-stage renal disease who's on peritoneal dialysis, presenting with unilateral facial droop, dysarthria, and weakness in her left arm as well as her left leg. The patient noted a history of Bell's palsy, but at the time of presentation reported that this was drastically different than the time that she had Bell's palsy. On exam, there was facial asymmetry on the left with significant dysarthria, and the patient of note was treated for genital lesions 3 days prior to the presentation in the hospital with valacyclovir. Going through the patient's labs and initial imaging, the CBC is essentially within normal limits, and looking at her basic metabolic profile, of course, the BUN and the creatinine do show some abnormalities, but again, our patient is end-stage renal disease on peritoneal dialysis. There was also a CT head and brain that was demonstrating really no acute intracranial abnormalities, and further into the hospital course, the patient had an MRI brain without any ischemic process. And of course, these symptoms persisted despite the patient's blood pressures being controlled after a couple days. We'd like to shift a little bit towards the mechanism of valacyclovir, as well as the role that it plays in clinical treatments. So, in terms of what we've been using valacyclovir for commonly, it's herpes zoster, herpes simplex, and chickenpox. That's first line, that's on label, the recommended treatments, and off label, it's often used for Bell's palsy and also prevention of cytomegalovirus, especially in patients receiving stem cell transplants. And so we'd like to kind of focus in on the fact that we're giving this treatment for herpes zoster, simplex, and chickenpox, but also Bell's palsy, which presents with facial droop. And looking at the mechanism of valacyclovir, the actual first step is conversion from valacyclovir to acyclovir using an HSV encoded thymine kinase. And after a few rounds of phosphorylation, once you actually interact and integrate yourself into viral DNA and some of the processes involved there, the acyclovir triphosphate, the phosphorylation process, actually stops HSV, herpes simplex, first line agent, from replicating. And so what we'll see is that valacyclovir converts to acyclovir and stops the transcription, translation, and true production of further HSV cells and HSV viral replication. And looking at the patient's hospital course thereafter, the neurology service saw the patient and evaluated her for a stroke and TIA workup, but had benign findings. Nephrology also saw the patient for continuation of dialysis, and speech language pathology was consulted at the first day of admission to look at the patient's speech and articulation, and this actually continued in the outpatient setting. And by day 3, after ruling everything else out in terms of strokes and TIAs, valacyclovir was discontinued, and it was found that 3 days in, the facial droop and dysarthria had essentially returned to baseline. In terms of our discussion, we'd like to point that valacyclovir, while it's not common, is a cause of facial droop and dysarthria. It's especially important to know that we use this medication for treatment of Bell's palsy. However, it can actually have the same side effects and present in the same way. We want to again reiterate the importance of a cranial nerve and neurological exam. Oftentimes we'll write nerves are intact or cranial nerve exam benign, but this actually kind of isolates and focuses on the importance of a good neurological examination. And we'd also like to understand the importance of adverse reactions and iatrogenic causes in presentation, and also potential therapeutic options for a known pathology presenting in the same way as Bell's palsy, the pathology we were mentioning. Thank you very much for listening to our presentation. We'd also like to thank Franciscan Health, Olympia Fields, and the Department of Internal Medicine for allowing us to participate, and ACP Illinois for creating this conference and allowing us to shed light on our case and also helping with our research experiences. Thanks again.